Yes, sir, we are live now.
Okay. So good evening, everyone, and welcome to another session of Postgraduate Endocrinology program from ISPE. So it's a virtual program running every 3 months, especially focused on the postgraduate students. So we will be discussing the cases which are important for the postgraduate learning, and we are introducing postgraduate endocrinology because endocrinology part is often neglected in PG teaching. So by this program, we are trying to teach postgraduates the essential endocrinology topics. So it's the brainchild of Professor Raghupati sir. So sir is busy in some events. Unfortunately, he is not able to join. So we will be beginning this program with the introduction to the program and its objective by our SP President, Dr. Anurag Vajpayee sir. So please introduce the program and officially start the program for today's session.
Thanks a lot, Dr. Jayvinder, and thanks, Dr. Jayvinder and Dr. Vijay, for continuing this very important work on part of ISPE. So, one of the major initiatives as far as the Indian Society for Pediatric and Adolescent Endocrinology is to increase awareness about pediatric endocrinology across different sections of caregivers as far as pediatrics is concerned. And definitely, pediatric postgraduates have always been the prime people who are very important from that perspective in providing direct care to children who have endocrine disorders. The concept of PEP had come, as Dr. Javinder was talking about, under the leadership of Professor Raghupati, who had started the program over a decade ago as a physical program. Initially, it was started in Bangalore, followed by Hyderabad and Coimbatore. So there were physical programs. We had one session in Kanpur as well. And subsequent to that, now with the advent of technology, this program has really taken up a new growth under the leadership of Dr. Raghupati and Dr. Amarnath, who has taken a lot of efforts earlier, and now Dr. Jayvinder and Dr. Jaiswal to cover that. So this is a very, very interestingly structured program which focuses on direct case presentation, discussion, expert inputs, followed by didactic lectures, comprehensively covering the different aspects of pediatric endocrinology. So I'll have say best wishes to the entire team who is conducting this program today, and over to the organizers to carry forward the program.
Thank you, Anurag sir. Thank you.
Thank you, sir, for your kind words. So now we will be starting the program. So today we will be discussing one common condition, pediatric obesity. So we'll be discussing it under two cases. One, we will be beginning with the case of simple obesity or exogenous obesity, followed by syndromic obesity. So the first case would be presented by Dr. Riya Shah. She is a fellow at Regency Healthcare Hospital, Kanpur, and she has been guided by Dr. Anurag Vajpayee sir. The examiner for the first case is Professor Asima Dabas. So she is professor at Maulana Azad Medical College, Delhi. She is a pediatric endocrinologist and she is an excellent teacher and researcher. She has various publications in various peer-reviewed journals and books. So we'll be starting the first case. Ria, you can start sharing. And Jignesh, there is a request if you convert Dr. Sam Kiran from attending into panel listening, please.
Thank you so much, sir. Shall I begin?
Yeah, you can start sharing your slides.
Yes.
So, Dr. Asima, you can interrupt Ria in between if you want to clarify anything or if you want to ask questions. So we have 25 minutes for case and followed by your lecture on approach to pediatric obesity for 15 minutes.
Yeah. You can begin, Ria. Yes, ma'am. Thank you, ma'am. Good evening, everyone. So a 8-month-old boy, resident of Kanpur, was brought to us. The informant is father, and the history seems to be reliable. He presented with the chief complaints of small phallic size noticed by the parents from last 6 months, easy fatigability from last 6 months, gradual weight gain from last 2 years, and increased appetite from last 2 years. In history of presenting illness, Patient was apparently well 2 years back when parents noticed gradual weight gain with tightening of clothes from last season. Although there were no weight records, it initially started from the trunk and later generalized. It was associated with increased appetite, with frequent demand of food and larger meal portions, but there was no food stealing history or binge eating or nocturnal eating. From the last 6 months, parents also noticed small phallic size, which was not increasing with age, although there was no history of trauma or urinary complaints. Parents also noticed easy fatigability in the form of easy tiredness during routine physical activity like climbing stairs or playing with the peers, and there was no history of dyspnea, chest pain, or palpitations. In negative history, there was no history of constipation or dryness of skin, no history of headache, nausea, or head trauma, no history of psychiatric illness, no history of vision or hearing difficulties, no history of any drug intake, no history of difficulty in rising from sitting or squatting position or lifting objects overhead, no history of increased urinary frequency, no history of sleep disturbances or snoring, and there was no history of hip, knee, and back pain. In the lifestyle history, his screen time, especially the non-academic screen time, was 3 to 4 hours. The diet was rich in junks, which is junk food, ultra-processed food, nutritionally inappropriate, carbonated, and sweet products. The physical activity was very low in the form of once to twice a week in games period only, that too for 30 minutes. And he used to sleep for 6 to 7 hours only and wake up early in the morning due to school hours. In drug history, there was no history of alternative medicines like Ayurvedic or homeopathic medicines. From the last 3 months, he was started on Tylenol 50 microgram by some private practitioner. In the past history, there is no history of chronic illness requiring prolonged steroid use or anti-seizure medication. In family history, he is the only child born out of non-consanguineous marriage. Father has history of type 2 diabetes and hypertension. Both mother and father appeared obese, and there was no family history of heart diseases. In antenatal history, there was no history of gestational diabetes, gestational hypertension, or thyroid illness, or excess weight gain in mother. In birth history, he is a term SJ baby with the birth weight of 2.2 kg, cried immediately after birth with no history of jaundice or hypoglycemia in neonatal period. There were no history of feeding difficulties in infancy, and weight gain thereafter was appropriate by the parent, as told by the parents. In developmental history, he has attained all the milestones as per age, and he is currently studying in 5th class with average scholastic performance. He is immunized till age. In dietary history, there was early introduction of formula feed within 6 months of life. He used to consume 2,630 kilocalorie per day. It is calculated according to 24-hour recall method, which is again 2,630 gram, which is kilocalorie, which is against the 2,190 kilocalorie, which is required for the age, which is around 20% of the excess. There was no protein deficit. And in socio-economic status, he belonged to upper middle class. Summarizing my case, a 10-year, 8-month-old boy born out of non-consanguineous marriage to obese parents, first in order, SJ born with uneventful antenatal history and poor lifestyle choices, was brought with the complaints of small phallic size, easy fatigability, and gradual weight gain. Presenting my differentials, the first and foremost is the exogenous obesity. The points in favor is, first of all, the age of onset, because the 90% of the patients in this age group presents with exogenous obesity. There is no developmental delay, no vision or hearing difficulties. There is no steroid intake history. He is an SJ baby, plus both the parents are obese, which makes him 80% at risk of being obese. Plus there are poor lifestyle choices. One point that we can say is against is the small phallic size, because we do not know if it is buried penis or micro penis, which will be clear in examination later on. Second differential will be acquired hypothyroidism, because this is also the age of presentation of autoimmunity. Plus, he's also already taking Tylenol, which means he might be diagnosed outside by some practitioner as hypothyroidism. But the points against are that there are no height concerns. Plus, there are no other features of hypothyroidism like constipation or dryness of skin. Plus, the severity of obesity is not that much in hypothyroidism. My third differential would be multiple pituitary hormone deficiency or growth hormone deficiency. The points in favor are the small phallic size can be explained by growth hormone deficiency. Weight can be due to hypothyroidism as well as growth hormone deficiency. However, severe short stature is missing here, and perinatal history is also uneventful. Later in the line is genetic obesity. The points in favor are increased appetite. However, significant hyperphagia is not there. Micropenis can point towards Prader-Willi syndrome. Points against is obviously the late age of onset. There is no vision or hearing defect, no history of developmental delay, and there is no history of consanguinity. Cushing syndrome, especially the exogenous Cushing syndrome, can present with an obese child with easy fatigability. However, there are no features of Cushing syndrome like stria or proximal myopathy. Thus, there is no obvious drug history and there are no growth concerns. Moving on to the examination. He is a well-looking child with stable vitals. BP lies between 50th to 90th centile for age, sex, and height. Height is 144 centimeter, which lies against 0.18 STS. Weight is 50.9 kg, which lies against 1.56 STS. And BMI is high 24.5 kg per meter square, which lies above 1.9 STS. These are the growth charts. And if we plot this on the extended BMI charts, we can see that the patient is obviously obese. He lies above the 27th adult equivalent. But to assess the severity, we can see that it is still lower than the class 2 obesity. In further examination, the sexual maturity rating is pre-pubertal. His testicular volume is 3 ml with a pubic hair stage of 1. Stretch penile length is 5.5 centimeter, which means it's a buried penis rather than micropenis. Waist circumference is 89 centimeter, which is more than 95th centile. There are no syndromic faces, volaceous stria, or brachymetacarpia, no dry skin or coarse skin, or no brittle hair. Acanthosis were present. It was grade 3, as we can see, and in systemic examination, it was within normal limit. So, finally, extending my summary with the examination finding, he is an obese child with high BMI, with no growth failure, and normal BP. He has buried penis with significant acanthosis, and there were no features suggestive of syndromic or endocrine pattern. Moving on to investigations, he came to us with following investigation.
So,
yes, ma'am.
Dr. Ria, if we can just stop here.
Yes.
Right. So can you just keep your summary slide here?
Yes, ma'am.
Okay. So do you want to enlist why these important pointers have been included in summary for the benefit of all students?
Yes, ma'am.
So one, history of family history. So the first word that you write is obese parents.
Yes, ma'am.
How does that relate to? Because,
ma'am, the history of obesity in parents increase the risk of obesity in child. If one parent is obese, there are 40% chances of a child to be obese. And if two parents are affected, so the 80% chances are there of a child to be obese.
And what you have also mentioned very nicely was their family history of associated hypertension and type 2 diabetes, if I'm not wrong. So
Yes.
even that would affect the rate of complications, which you are going to discuss now.
Okay.
Right? The
Okay.
second is you also presented very nicely the antenatal and the birth history. What relevance would that have in a child who comes to us with obesity?
Ma'am, birth weight plus prematurity becomes an important risk factor because this SGA childs are at so much risk of childhood obesity later in life. So we must ask about the birth weight.
Yes. So SGA by itself does put the child at risk of metabolic syndrome. Also important is when you took history of maternal GDM, right, and any other maternal complications, even those would increase the risk of obesity in early childhood.
Yes.
Right, and poor lifestyle was very well described by you, which we could take. You did mention some exercise for half an hour.
Yes.
Do you want to discuss in detail what that exercise was?
Ma'am, basically in the school, in the PT class, when he was asked to run, like mainly the exercise was in the form of running. So in the ground, they were asked to run. So that is what he used to do. Like he said, for 30 minutes, he used to rest and run, like in between.
So age appropriateness, whether it is aerobic, anaerobic, and
This
duration.
aerobic,
All that
this-
had to be, so this was obviously not a structured exercise, which we can call as exercise. It was just running.
Okay.
And that too non-supervised. Okay. And then you discussed the examination findings very well. Okay. You also mentioned about the development history.
Yes, ma'am.
Any other clues that you would want to, I mean, why is it important for us as a doctor to take a good development history in children who present with obesity?
Ma'am, developmental history is very important. First and foremost, to exclude the syndromic causes, because syndromic obesity will present with the delayed developmental milestones, or in fact, besides that, there should be psychological evaluation as well, because obese children are at increased risk of depression. Plus, in development, it's very important to but like for age appropriate development is there or not, mainly for syndromic causes.
Okay, so I'll just add one more point. Yes, agreed, syndromic causes will be associated with some developmental delays, but probably a commoner group that we see are children with neurobehavioral problems. And as you rightly said, many of these will need psychosocial assessment, because sometimes it is the psychosocial underlying behavior which could be difficult to treat. Maybe they are even unidentified for their autism or some other behaviors, because of which our compliance to lifestyle will not work. Right? So even
Yes,
that is important when you are taking development history. So also include behavioral patterns in your history.
Okay, ma'am.
Okay. Right. So now I think we can proceed further with investigations.
Thank you. Moving on to the investigations. So he came to us with the following investigation dated 3 months back, in which the hemoglobin was 11.1, TSH was elevated 8.2, total T4 was done, which was in normal range. Testosterone was done in view of small phallic size, which was 0.03 nanogram per ml. On the basis of these investigations, a diagnosis of hypothyroidism was made and he was started on Thyrono. These are the investigation that we did. SGPT was normal, 18.8 units. Creatinine was normal. FT4 was done, which was normal, 16.32 picomole per liter. TSH was mildly elevated, 6.8 millionton unit. Fasting blood glucose was 112 milligram per deciliter. On OGTT, postprandial blood sugars were 156 and HbA1c was 5.9%, which makes him pre-diabetic. Total cholesterol was 156 milligram per deciliter. Triglyceride was 109. HDL and LDL were also normal. Which brings me to my final clinical impression, which is 10-year, 8-month-old child with obesity, most likely exogenous obesity, with buried penis, with subclinical hypothyroidism and prediabetes.
Right.
Thank you.
Would you want to go back to your investigation slide?
Yes, ma'am.
Can you interpret what is normal, what is abnormal here?
Yes, ma'am. So SGPT was done to rule out the fatty MSALD and it was normal. In the thyroid profile, we can see that TSH is mildly elevated, but the free T4 is normal. In the sugar profile, the fasting blood glucose is impaired. Postprandial is also impaired. So there is impaired glucose tolerance as well as fasting is impaired, which suggests that it is pre-diabetes. HbA1c was also done and it is also in the pre-diabetic range. Lipid profile is normal.
Right. So he has some features of derangements on the metabolic profile. But if I remember, his blood pressure was normal, which you had taken.
Yes, ma'am.
Okay. He also had significant acanthosis. So can you relate some parameters here?
Yes, ma'am. So acanthosis tells us about the insulin resistance, and patient is also having dysglycemia. So we can see that the patient is moving towards the metabolic syndrome. It is still not metabolic syndrome because it does not fulfill the criteria, but he is moving towards the complete full-fledged metabolic syndrome. So we must act here only to.
Right. So just last question. Any risk factors that you have been able to identify? Because then we will have to start working on those in this child.
Ma'am, risk factors in the child of
I mean, in the environment, we understand you mentioned a very good diagram of
yes, ma'am.
the lifestyle details, right? So if now you have to work on this child, especially now that you understand, I mean, because this child is also taking thyroxine, also is going towards a metabolic syndrome. So we will deal with the medical part later, but what in the environment would you start working on?
Okay, ma'am. First of all, I'll start with the lifestyle modification, which is the cornerstone in obesity management. So, since we have seen that the diet choices are very wrong, I can say that there was a lot of fast food, and so what we can do, then we can make a family based approach. We can counsel the family that change the dietary choices, not just for him but as a family itself, so that everyone eats healthy and he gets motivated to eat healthy. Plus, second, we can start with increasing the physical activity. We can ask the parents to get him a cycle and increase the physical activity per day. We should increase. Plus, the most important, the screen time was very high. It was 3 to 4 hours, which should be reduced to 1 to 2 hours. And another thing, he belonged to upper middle class, so he must be having so much access to the markets and the fast food, so it should be cut off. So basically, counseling is required.
Dr. Ria, just one question from my side. What I can see here that after presentation that you are thinking that this is a case of simple exogenous obesity or say nutritional obesity, right?
Yes.
And you have labeled this subclinical hypothyroidism.
Yes, sir.
So whether we can change for something else because in this scenario, or you still want to label as subclinical hypothyroidism?
Sir, since there is a mildly elevated TSH, but T4 is normal, so this is subclinical, sir. By definition, it is subclinical hypothyroidism. But obviously, we do not need to treat it as such. So
what I understand, we may have to have a relook at this TSH and the thyronorm that he's taking, whether it is really an autoimmune hypothyroidism, because this is control on that medication. So his records have to be reviewed, and whether he really needs that thyronorm or not also has to be rechecked.
Sir, ma'am, just report pe he was started. It was TSH was elevated and total T4 was done. Although no free T4 was not done, but it was also normal. So yes, we should do TPO antibodies to review if it is autoimmune thyroiditis.
So Kavita ma'am has raised her hand. She want to ask one question. Ma'am, please.
Yeah, Dr. Ria, that was an excellent presentation. A few things that occurred to me, I was like making points about your. One thing is an SGA. This child was an SGA child, and probably had a very early adiposity rebound. So there's this thing called adiposity rebound. If you see the BMI chart, there is a dip between the ages of around 2 to 5, and then it starts increasing, right? So children who have an early adiposity rebound, especially children born SG, are metabolically at very high risk. That is one thing. And the second thing is, again, the small penile length. Did I miss it? Did you measure it? Because there are charts to measure and compare it with, there are 10 percentiles chart. Did you do that?
Yes, ma'am. I did the stretch line length. It was 5.5 centimeter, which was more than the minus 2.5 standard deviation that we take for.
Okay, fine. So now there is a concept called obesity-related hypogonadism, or male obesity-related, hypogonadism, because obesity causes suppression of the hypothalamo-pituitary gonadal axis, a functional suppression. That is the theory. Adipose tissue produces many inflammatory cytokines and leptin, insulin resistance, which itself suppresses the hypothalamus and pituitary. And that's why many obese children actually have about 10% lesser penile length. Studies have shown, in recent journal articles it's come out, that adolescents could have this, and having a small penile length secondary to obesity itself is not uncommon. Fat tissue has an enzyme called aromatase. The expression of aromatase enzyme is increased in obesity, and that alters the testosterone to estrogen ratio, and that can also contribute to this. So that is as far as the penile length goes. And the thing about thyroid dysfunction also, there is a theory about these inflammatory cytokines and leptin increasing the TSH, the set point for TSH release and causing subclinical. And you should be very clear when you're saying subclinical, TSH less than 10 and more than 4.5. That is subclinical with normal T4. So when we are presenting any case, we should be putting forth the concepts clearly. So that is another theory for subclinical hypothyroidism. And subclinical hypothyroidism usually does not require treatment unless and until it's more than 10, except there are a few exceptions. One is if there is a goiter, if there is a thyroid swelling. Second is if there is a lipid dyslipidemia or if autoantibodies are positive, in which case we need to start treatment even for subclinical hypothyroidism. And this is far as my knowledge goes. I just thought I'll just make these points, Dr. Jaiswal, if it's okay with you.
Thanks a lot,
Yeah,
Dr. Kavita. May I add a couple of points regarding my own in terms of management of this case and further issues from that perspective? So definitely,
Sure.
yeah. So just to emphasize on the hypogonadism, I think the key message which we also want to give in this case is that this is a 10-year, 8-month child, and we should not be considering this as a hypogonadism because this child will anyway have a low LH, low testosterone. And we should not give a message that if they get the levels done now, it will always be low. So there's a famous saying that there was a 12-year-old child who was referred with hypogonadotropic hypogonadism because everybody who is 12-year-old will be hypogonadotropic hypogonadism. So I think what is important to emphasize here is first whether we really have micropenis or not. That's very important. And I entirely agree with Dr. Kavita that extreme obesity at very high level, when, as she said, that when the aromatase is very high and estrogen is very high, that does cause the suppression. Usually we see that in younger individuals somewhere around 16 to 18 years who are like 120, 130 kilograms. So that is something which is a very, very important distinct entity. But do not get confused. But this level, Dr. Kavita was talking more in terms of the other theoretical aspect, which is important, but not from this case perspective. So because unnecessarily we see so many workups happening in these cases, which is not required.
Yeah, true, Dr. Anurag. I mean, I missed out the age. It is just 10.5 years. I agree with you. We need to have a bone age of at least 12 years before we actually think of hypogonadism. You're right. Sorry, I missed the age.
And just a word on subclinical hypothyroidism, we had done a big study in which we worked out and we found that out of 250 individuals, 30% actually had subclinical quote unquote 4.5 to 10 TSH with a normal TPO and a normal FT4. And the only thing which correlated with that was that they had a higher level of ALT and a higher chance of MASLD. So there are some effects of this thyroid perturbation which are happening in these children, but that does not mean that that will require treatment from that perspective. So this is a very important entity. From a pediatric postgraduate perspective, TSH less than 10 does not require treatment. I think that is something which is very important, and get a TPO done. Even if TPO is borderline, don't treat, maybe wait and watch. The biggest message I would say from this case is this is a SGA with a rapid catch-up, and we already are seeing pre-diabetes happening. This child is having pre-diabetes, and what we have shown in our Indian data as well, as that 30 to 40% of these individuals will persist to have pre-diabetes and may progress over time as well. So this is a very important thing. And what has been shown in Indian children is that if you lose 5% of your BMI SDS, you may revert pre-diabetes. So this is the easiest phase to revert. Once this child develops diabetes, you will need 10% BMI loss. Once the child develops established MASLD, you will need 15% BMI loss. So this is the best time to work in terms of gaining maximum output from there. So I think pre-diabetes is something which we should not just brush under the carpet. This is the time to really work on it. And that is something, a big message I like to give from that perspective. And this is a quite common scenario that we see. Thanks a lot, Dr. Ashima, for the wonderful conduct of the case here. And thanks, Riya, as well.
Thank you, sir.
Thank you, sir.
Thank you, I think, Kavita ma'am and Dr. Anurag sir, for your very valuable inputs. And I would also agree. I would, in fact, also add one message to what Dr. Narag was saying. For dysglycemia and all these metabolic screening workups, you actually don't need very hi-fi investigations. So knowing that this is insulin resistance and you can see that clinically with the examination, please, there is no need to order insulin and then keep calculating weird indices. It will only panic the parents more and just put in more money. And OGTT serves your purpose very well, and probably even to monitor that should do. So I think with this, we can quickly move to some key summary points which I've prepared for the students. So Dr. Ria, if you can stop sharing. Thank you for an excellent case presentation.
Thank you so
And
much.
for all the correct answers.
Dr. Ashima, can I ask a question? Dr. Ria?
Yes, ma'am.
Dr. Ria, although you have presented a very good case, you have covered almost all the practical points. I just want from you a theoretical question. What is the role of maternal nutrition in obesity? Can you just tell?
What, ma'am? Maternal?
Maternal nutrition.
Okay.
What is the contribution of?
So, ma'am, if there is excess weight gain or even undernutrition, both will put the patient into the risk. For example, if there is undernutrition in the mother, it will make the baby at risk of SGA. There will be IUGR, and that will again cause this childhood obesity. And if there is excess weight gain during the pregnancy, that will make the mother at risk of GDM, and which will further cause it will produce an IDM baby, which will again cause obesity. So,
And what is the role of gut microbiome?
What, ma'am?
Gut microbiome. Is
Gut,
there any role?
gut microbiome, yes, ma'am, there are studies which says that if there is alteration in the gut microbiome in the child, it can also lead to obesity.
Okay.
I will not know in detail.
Okay, fine. Thank you.
Okay.
Ria, you can stop sharing your slides as we are running 2-3 minutes late. Dr. Ashima can start our presentation.
Where to unshare? I'm trying to
Stop sharing.
stop.
Share
Okay,
me
okay,
that.
okay. Thank you, sir.
Yeah, thank you.
Okay.
So in the interest of time, I'll keep my presentation short. And
So you have 20 minutes, Dr. Ashima, so you can finish in 20.
so I hope my slides are visible.
Yes, your slides are visible and you are audible.
Thank you. So Dr. Ria has presented a very lucid case, and we've had a very nice discussion, which has actually covered a few of the essential points that we would be worried about when we are talking of management of child. It is rise across all ages, children more affected, and obesity is not just increased body fat, it can also other conditions which we may miss if we are only using some simple markers or standards to measure. Sorry. Yeah, sorry, I'm just sharing my screen again. Yeah. So we understand that obesity, the burden of obesity is increasing. It's increasing in both younger children and adolescents. The prevalence overall has increased. And what is more sinister is that this obesity tracks till adulthood. And it is a harbinger of all adult onset non-communicable diseases also. India, by the sheer numbers that it has, is actually has the second highest number of obese children in the world next to China. So the situation is very, very alarming. And the fact that normal obesity can be detected in time, can be prevented, is what gives the impetus for us to understand obesity better. So remember, for obesity, even though it may not mean, it means increased fat, but what we are measuring as BMI is just increased weight usually. But it may still remain the most common parameter that we use to measure children for obesity. So a similar case, I can skip the case because the case has already been discussed very well by Dr. Priya. But yes, what was very nice and has to be done by all pediatricians who are looking after children, please use the growth charts. So growth chart and the IEP growth chart, which also we see, the area of weight around the puberty shows a little bit of fanning, right? So when you plot the weight, and if you were to look at weight age or something like this, it may still not corroborate with what you're seeing in the child. Second thing which is important to understand when we are seeing children with obesity is how is the height in relation to weight, and whether height is actually short or whether on the higher side of the growth chart. Remember, children with constitutional obesity are not supposed to be short. So I understand that the weight will be higher than the height centile, but the height cannot be short. If you are seeing a plump and a short child, then it is not something where only lifestyle needs to be done. This child will need workup. What you also see in the insert of the 8 to 18 years for 8 to 18 years is a simple weight to height screening tool. So here, if we use the height and we plot the weight, we can classify the child into overweight, obese, or normal weight. So this works as a quick screening tool instead of calculating a BMI and plotting it on the chart, which you can see here. However, for understanding the risk of obesity in terms of morbidity and complications, this BMI is going to be very helpful for us because we know that children who are at in the higher class of obesity are likely to have more complications and morbidity patterns, and these children may need more intensive therapy. When I'm saying therapy, it is not just lifestyle. It will not work unless it is made intensive. So to make it intensive, it will need a multidisciplinary team where the doctor, pediatrician, dietitian, counselor, a physiotherapist, all have to come together. Right? So these are the body mass screening tools that we have. And these are easier when you're sitting in a busy OPD and you may not have time even to use the growth chart app to check the standard deviations. But yes, at some point that should be done to estimate and monitor, to record the blood pressure. So I think the approach to obesity actually begins with assessing the risk factors first, because these are the areas where we have to be working with the child and the family to probably prevent or to start getting that change which we are looking at, which is the delta change in BMI, where BMI starts falling and the rest of the investigations and the dysglycemias would start correcting. So very important is the concept of motivational interviewing. And I think Dr. Ria did mention the role of how a counselor, the involvement of a counselor becomes very important early in management plans. Knowing that obesity is always to do with some environment factors, but is also to do with what happens in the mind of the child. So acceptance, partnership, evocation, what does the family think they have? Unless they are in tune to what you want, some compassion. The family and the child is trying to get better, but may take a lot of time to get better. And last we have to do is what we all are very familiar doing is medical evaluation. So identifying red flags early. Is this growth pattern following what a normal constitutional obesity will follow or not? So what was the onset of obesity and how is the progression of obesity? So as in the index case which was presented, it started around mid-childhood. The child had always been chubby and the progression happened slowly, started with the trunk and gradually the child started gaining weight. Unlike a case where obesity may happen very early, may progress within few months, there a red flag has to be raised. Also assess complications. So this child, our index child, was not able to participate or run very fast. Is it only that he's not interested Or is there something else which is making him not try? He's sleeping less, right? So does he have an obstructive sleep apnea which is missed, because of which he's not able to sleep and because of which he's not able to perform in the day? So all these complications come hand in hand, which have to be assessed. Finally, lifestyle and pharmacotherapy plus minus is what we work on. So I think some questions related to the risk factors and the environment were discussed. So if we look at the child, genetics plays a role, ethnicity plays a role, and Indians by their virtue of being Southeast Asians and Indians are at risk of more metabolic complications. And there's enough data from India which has shown the risk that their risk is higher for type 2 diabetes, hypertension, and other cardiovascular problems. Birth weight, especially antenatal care which the mother received, and how maternal parameters would be influencing the baby's growth in the early infancy has also been reported well. So even a good antenatal care forms a very good prevention strategy for preventing childhood obesity. Finally, for the child, focus on diet. So when we are talking of diet, it is not just amount, but also quality of food. So even if he's taking those 2 chapatis, whether it is all maida or whether it has some millets, will make a big change in what the child ultimately consumes. Sleep hygiene has to be emphasized, especially in this post-COVID era, and with children having more addictions to social medias and commitments with the school. This becomes important when we are addressing the risk factor. Physical activity, as we mentioned, only the fact that there is a PT period and the child is running in the school is not physical activity, unless it is structured, unless it is tailored and personalized to meet a demand, to meet a energy consumption demand. It does not quantify to be a physical activity. And what I've shown is the first 1,000 days of nutrition, which has now been actually extended to the first 2,000 days of nutrition. So this is the first part, is the pre-pregnancy and the prenatal period. Then is the first year of life, where breastfeeding practices, adequate complementary feeding becomes important. And finally, the second year, where the child has to learn to eat from the family pot. All this is part of your history, which has to be taken. The environment risk factors need to be assessed, because we will have to be working on these parameters also. We have to make the child lose weight. So you have to work on what all obesogenic environment triggers are there in the household. Is the family motivated enough to help the child lose weight? So I think I really like that concept when Dr. Ria said, we will work with the family and make the parents also work with the child. So that has to be addressed. Okay. So we should, at any point where we are seeing a child with obesity, we have to rule out any other pathological disorder where we are likely to miss, if we don't identify the red flags early. And I think the second talk is going to talk about what all disorders can present in children who present with obesity, who are not constitutional and who are not nutritional. So I will, in the interest of time, I need not read all these. I am myself waiting for Dr. Kavita's session. But yes, some clues that we have to be very alert about. So any early onset obesity, please identify. Any obesity below 6 months of age is not normal. Also look at patterns. So as ma'am mentioned about obesity rebound, what is the age where obesity actually began to happen? So we also understand during the peripubertal period, children may have some increase in BMI, but if it is rapid at that time, or if it is excessive at that time, please mark an alert. Any developmental delays, any seizures, any neurobehavioral disorders also have to be identified, right? Any other subtle clues like hypotonia, feeding difficulty, because these can give you a hint of underlying syndromic disorders. Any polyphagia which is out of proportion. So binge eating, agreed, but sometimes children would get up in the night to eat food. So please don't take that as something which is just a pampered child. This is something which should throw an alert that this child will need further evaluation, and especially insomnia. So insomnia could both be associated with poor sleep quality and resultant, but generally insomnia is not a good feature and should alert you to something which will need further workup. So this is the list of all complications that need to be screened in children. All may not need investigations on the first go. Please strategize and prioritize your investigations in the first go, and ensure that the child follows up with you, so that once he comes with that so-called subclinical hypothyroidism, and you tell him that within 4 weeks, it may come down to normal, provided you follow this is one of the ways you can take him on board for your lifestyle lifestyle modifications. One thing which I would emphasize is the history of obstructive sleep apnea. So please take a minute to always ask whether the child is snoring or not, because this may need some further evaluation. And in rare cases where lifestyle doesn't work, they may actually need a referral to a pulmonologist. Metabolic dysfunction, especially of the fatty liver, is well reported, seen in almost 25 to 30% or even more proportion, depending on the severity of obesity. So this needs to be screened. And sometimes these children may have very vague musculoskeletal pains. Vitamin D deficiency may be indirectly or commonly associated, and this also needs to be addressed. But also remember to address their psychosocial concerns. These children are at very high risk of being bullied. They may have depression and anxiety. And unless this gets identified and addressed, your lifestyle compliance will never happen. A word about metabolic syndrome and how obesity itself is not just a weight problem, but actually involving the entire system of the body, happening at the molecular level. And all this, even if it doesn't translate to things which can be measured in childhood. So what if there is some oxidative stress? It may not be discernible now, but remember, it is a harbinger of what might happen later. So early stroke, early MIs that we are seeing nowadays is probably what we have missed in childhood. So we all know the criteria for metabolic syndrome in children and adolescents. So generally, we would be able to classify children who are more than 6 years of age. We need a parameter of central obesity, which is usually the waist circumference. We have Indian charts and we survey where they have published as to what are the normal centiles for weight circumference, plus 2 or more of the following. So this is elevated triglyceride, low HDL, elevated blood pressure, or elevated blood glucose or dysglycemia. If any 2 of these is present, then this child can be classified as metabolic syndrome. And this child will definitely need more intensive lifestyle modifications and more intensive follow-up to ensure that he doesn't progress. So some children may need all of these investigations very soon. And there is a whole list of these children who are at risk. So overweight and obese children more than 10 years, any child who has a family history of obesity, dyslipidemia, or type 2 diabetes in first degree relative becomes a high risk. Low birth weight and a rapid catch-up is also not a good factor. So these children also have to be kept on alert. And other conditions where they could be associated insulin resistance, some other high-risk conditions where even underlying chronic kidney disease, etc., may put these children at higher risk for poor cardiovascular outcomes. So by and large, presence of these conditions doesn't mean that the child has constitutional obesity, but at a higher risk of metabolic syndrome. So last few minutes, I'm just going to cover the basic principles of management and approach how we manage. So the Ending Childhood Obesity gave these very good 6-point module of how to address obesity. So the first is promote intake of healthy food, right? Limit junks. And I think Dr. Ria mentioned of how important it is to elicit intake of all these components separately. Second is promote physical activity. And I think we have discussed that enough. They would need 60 minutes of moderate to vigorous physical activity daily. Now, this again has to be age appropriate. So every child can't do a skipping session. Swimming may not be possible to all, but something which is age appropriate can engage the child and can be moderate to vigorous such that the child does sweat and does lose energy. Third, the role of preconception and pregnancy care, of how maternal BMI, maternal diet, and maternal microbiota would affect the chances of obesity in later age. Effect of early childhood diet and physical activity, not to overemphasize, but the role of exclusive breastfeeding, timely introduction of complementary feeding, and early childhood development. Finally, the role of school and the role of pediatrician. So school in terms of what is the activity, what is the diet if they are serving, and what is the psychosocial development that they are doing at school. And for pediatricians, growth monitoring. So please at least 6 monthly group plotted on a growth chart on those routine follow-up visits, and a blood pressure to be taken in all children more than 10 years of age. Management would mainly focus on two pillars. One is dietary and one is lifestyle, but this can happen together only if it happens as a team. So a traffic light approach has been worked very well in with children, where you label foods as red, yellow, and green. Red is something that the child should not be eating. Yellow is something which can be eaten sometimes in smaller amounts, and green is what the child can eat plenty. So fresh fruits, vegetables, salads are all greens. Encourage more fiber intake. So age plus 5 grams is what is the recommended fiber intake. And any day millets would have more fiber than plain wheat or rice. So ask them to include more millets. It is cheap, it is more cost effective, and it offers a variety to the in the menu. And definitely limit all junks, including sugar sweetened beverages. Exercise we've already talked about, and limit the screen time. Right? But just giving instructions will not work unless this gets followed up with compliance and we ensure that the child has done monitoring. So I need not speak on pharmacological management. Just to remember, there is no standard pharmacological agent. Liraglutide has been introduced, which is the new GLP-1 analog, but the indications of starting it, monitoring it, and how to give are a very, very restricted area. I would suggest against starting liraglutide early, right? And as per the IAP 2023 guidelines, these are very nicely compiled guidelines. I will request all postgraduate students to please read. They have very clearly indicated when can pharmacotherapy be given, which drug to be started, how will it be monitored, and where do you stop, right? So each drug has a lot of side effects. So all of us should be knowing that starting pharmacotherapy is not the answer, because there will be a rebound weight gain as soon as we stop. So I think I will just stop with this. So if we were to remember a management plan for obesity, remember it is always prevention plus first, screening for comorbidities, maintaining a weight is important, giving guidelines of structured weight loss become important on follow-up, and finally it is what you do as a team. So it is only teamwork which can help and not a single doctor alone. Thank you.
Thank you, Dr. Asima, for a lucid lecture. You have clarified many things and simplified the approach. So thank you very much for accepting the invite and giving a good lecture and good examination for the case. So now we will move to the second case, and I hand over to Dr. Vijay Jaiswal for the conduction of the second case discussion.
Thank you, Dr. Javinder. This was really good to listen this nutritional obesity, and this is the commonest thing what you encountered. Now, second is really important, that when to say that it is pathological and these obese children need to be investigated. So this is the case 2, which is going to be syndromic obesity. And Dr. Soumya is going to present the case. He is DNB student at Manipal Hospital, Bengaluru. And the guide is Dr. Shyam Kiran. He is Assistant Consultant Pediatric Endocrinologist. And examiner is none other than teacher of teachers, Dr. Kavita Bhatt ma'am. And she is Consultant Pediatric Endocrinologist at Manipal Hospital, Yelahanka. So I invite Dr. Soumya for her deliberation, please. Dr. Soumya, you can proceed.
So somewhere your screen is visible, you can start your case presentation.
Dr. Soumya, you are not audible.
You can stop sharing and share again. It may help. We are able to see your slides, but your voice is not audible. Are you unmute? On your screen you can see.
So Soumya, you can share your slides on the WhatsApp group. I can share my screen and you join from your phone. Your laptop audio is not working. Don't worry. Share your slides on the group. I'll share. And you join from your phone. Yeah, I've got the slides. Just give me a minute. Meanwhile, you can log in from your phone, okay? And stop sharing so that I can share my screen. Is this visible?
Yes, Dr. Asima, it's visible.
Yeah.
Am I audible now, ma'am?
Yes, yes.
Yes.
Yes, you are audible.
Okay, sorry for the inconvenience, everyone. So I'll start my case presentation now. I'm presenting a case of ABC, 7 years, 6 months old, male child, date of birth being 14/11/2018, hailing from Chennai, informant being the mother. Chief complaints, rapid weight gain noticed for 6 months and aggressive behavior noticed for 6 months. History of presenting illness. This is a 7 year, 7.5 year old male child brought with complaints of excessive weight gain with recent acceleration over the past 6 months, associated with increased appetite, food seeking behavior, and aggression around the food. They reported that he was very thin around the age of 2 to 3 years. Then the parents noticed gradual weight gain despite no proportional increase in food from 4 to 5 years of age and increased weight gain of around 10 to 15 kgs over the last 6 months. A week, seeks food at night, is persistent with food ideas, try to steal food few times a week. Parents feel his food associated behavior causes mild interference in completing schoolwork or hygiene tasks. He's becoming very rigid gets aggressive, especially around food. Be told and what shouldn't. He has difficulty with nose at night, frequently gets up, gets easily disturbed, sleeps in school and wakes up late on holidays. Next slide, ma. They deny any history of constipation, feeling excessively cold or dry skin, denies drinking excess water, passing urine frequently, bedwetting, denies easy skin bruising, intake of steroids in the form of nasal spray, inhaler or tablet, denies seizures or early morning headache, no history of any limb anomaly, polydactyly or vision abnormalities, no long-term intake of alternative medications like Ayurveda or homeopathy. Past history, he underwent exploratory laparotomy followed by orchidopexy for right undescended testis at the age of 2 years. Antenatal history, he was mother was primigravida with only significant antenatal history of decreased perception of fetal movements during the periods of stillness, and the labor was induced at 40 weeks and delivered by a normal vaginal delivery. Birth history. Baby had weak cry at birth and decreased spontaneous movements. Baby was kept in NICU for query neonatal sepsis, and baby was born with birth weight of 2.5 kgs. Baby was reportedly continued to have weak cry and decreased activity during the first month. He had poor suck and difficulty in breastfeeding. They used bottle feeding. That too, mother felt he was too tired and didn't have strength to feed. Mother recalls that even a single drop of milk he used to choke. At 6 months, they introduced complementary feeding and slowly his feeding improved. Family history, his first born to non-consanguineously married couple. No history of obesity in either of the parents, and both sets of grandparents have diabetes and hypertension. Dietary history, calculating his total dietary intake, total intake of calories being 2,460 and proteins of 70.7. And he is calorie excess of 760 calories and protein excess of 45.4 grams of protein. And he eats a lot of junks, that is pizza, burger, fries, cola every other day and feels always hungry. And he throws tantrums if food is not given to him. Developmental history, he attained all milestones, but there was a delay. Neck control at 10 months, standing at 16 months, and he walked only after 1.5 years of age. And predominantly, he has motor and speech delay. Developmental quotient, gross motor 52%, fine motor 65%, social 65%, and language 55%. Summary, 7-year, 6-month-old male child born to a non-consanguineously married couple with an antenatal history of decreased perception of fetal movements and postnatal admission to NICU in view of neonatal sepsis. There was history of decreased spontaneous movements and feeding difficulties during infancy with delay in attainment of all developmental milestones, notably language and motor milestones. The child was brought to us with complaints of rapid weight gain noted over the past 6 months, associated with aggressive behavior noted over the past 6 months. Differential diagnosis. So, considering the history of infantile hypotonia and later on onset of hyperphagia and rapid onset weight gain, we would like to, with history of developmental delay, we would like to consider syndromic obesity as our differential diagnosis, and syndromes that could be Prader-Willi syndrome, Bardet-Biedl syndrome, because even that has a history of that includes hyperphagia, but there are no vision abnormalities or any history of polydactyly or limb anomalies. Beckwith-Weidman syndrome can be considered, or it could be just a simple exogenous obesity. Examination. General appearance of the child. The child is sitting comfortably on the bed, alert and oriented. The child appears to be obese with syndromic faces, and acanthosis nigricans is seen on the neck. Vitals: heart rate 89 beats per minute, respiratory rate 23 cycles per minute, CFT is less than 3 seconds, BP 92 by 60 mmHg, which is normal, temperature 98.7 degree Fahrenheit, all peripheral pulses were well felt. There is no radial or radiofemoral delay. Anthropometry: height of 110 centimeters, which is less than the third centile for his age. Weight of 45 kgs, which is more than 97 centile. BMI of 37.19 kg per meter square, which is more than 97 centile. Head circumference of 50 centimeters, which is normal. Waist circumference 102 centimeters, which is more than 95th centile. His anthropometry being plotted, height, weight, and BMI. Height is less than the third centile. Weight of, next slide, ma'am. Weight is more than the 97 centile, and also BMI is more than the 27th centile of the adult equivalent. Head, ears, eyes, nose, and throat examination. These are the representative pictures, as the parents did not consent to give us the child's pictures. He has dolichocephalic head shape with almond-shaped eyes, upslanting palpebral fissures, downturned corners of the mouth, small hands and feet. Oral cavity, there's no tonsillar enlargement or no goiter. Skin acanthosis present over the neck, axilla, and groin, and multiple striae over arms, trunks, and buttocks. Genital examination: testicular volume, bilateral testis of 2 ml with stretched penile length of 5 centimeters, which is Tanner stage 1, and pubic hair stage, Tanner stage 1. Systemic examination: nervous system was suggestive of hypotonia on examination. Summary after examination: a 7-year, 6-month-old male child born to a non-consanguineously married couple with antenatal history of decreased fetal movements and neonatal NICU admission for query sepsis, had decreased spontaneous movements and feeding difficulties in infancy, and global developmental delay involving majorly motor and language milestones. He now presents with rapid weight gain and aggressive behavior. On examination, there is severe obesity with short stature, syndromic facies, hypotonia on neurological examination, and prepubertal sexual maturity rating with pubic hair Tanner stage 1 and genital Tanner stage 1. Overall, the clinical picture is suggestive of syndromic obesity. Red flag signs suggestive of syndromic obesity by history and examination. There's early onset obesity with short stature, rapid weight gain during the first few years of life. There is history of hyperphagia and dysmorphic faces on examination, associated features being developmental delay, infantile hypotonia with feeding issues, behavioral problems, and also sleep disordered breathing. And there is hypogonadism. Differential diagnosis being Prader-Willi syndrome as my first differential, and Bardet-Biedl syndrome being my second differential, but there is no history of any vision abnormalities or polydactyly on examination. On lab investigations, his TSH FT4 was normal, ATM cortisol was normal, AST was 23 and ALT was also normal. HbA1c was 5.6%, FBS being 98 mg per dl, which was normal. Serum insulin was 3.4 micro international units per ml, which was normal. Total cholesterol was 230 mg per dl, which was increased. Triglycerides was 167 mg per dl and LDL was 154 mg per dl, which is suggestive of dyslipidemia. Genetic testing was done, methylation specific multiplex ligation dependent probe amplification, which reported as deletion involving 15q11 region detected, which is confirmatory of Prader-Willi syndrome. Sleep study was done, OAHI of 15.7, which is suggestive of severe OSA. Bone age X-ray by Tanner's White House 2 method is suggestive of 4.8 years, which is delayed. Insulin-like growth factor 1 levels 54.5 nanogram per dl, which corresponds to minus 1.1 standard deviation. So integrated case summary after investigations. A 7-year, 6-month-old male child, first born to non-consanguineous parents, had antenatal decreased fetal movements, weak cry, and decreased spontaneous movements at birth. Neonatal NICU admission for query sepsis. There is poor suck or choking with feeding difficulty in infancy and delayed motor and speech or language milestones. He now presents with rapid 10 to 15 kg weight gain and aggressive food-related rigidity for 6 months with hyperphagia, food foraging or night seeking, and food stealing. Examination shows severe obesity with short stature, syndromic facies, small hands or feet, hypotonia, and prepubertal genital findings. Investigation shows dyslipidemia, severe OSA, delayed bone age, IGF-1 levels at -1.1 standard deviation, and MLPA deletion involving 15q11 region. So, early clues to my diagnosis, there is decreased fetal movements, weak cry, neonatal hypotonia with poor suck or feeding difficulties, and right undescended testis. Current phenotype, there is rapid weight gain of 10 to 15 kgs. There is history of hyperphagia with food seeking, aggression around the food. Development wise, there is global delay, majorly involving motor, speech, or language predominantly. On examination, there's severe obesity, short stature, syndromic facies, small hands and feet, and hypotonia. Genitals corresponding to prepubertal Turner stage 1. Lab reports suggestive of dyslipidemia, 15q11 deletion, confirmatory of Prader-Willi syndrome, and OAHI of 15.7, which is suggestive of severe OSA. So my final clinical assessment would be Prader-Willi syndrome in nutritional phase 2B with severe obesity, hyperphagia, severe obstructive sleep apnea, developmental delay associated with hypotonia, short stature, and dyslipidemia.
Yeah, thanks, Dr. Soumya, for your nice presentation. Just I have some queries that what was the first point of contact when you thought that this patient might have syndromic obesity or this child will require investigation? So yes, so for just learning purpose for PG, again they have to see that what are the pointers to think for pathological causes of obesity. Please go ahead once again.
Okay, so the antenatal history of decreased fetal movements and history of decreased spontaneous movements and feeding difficulties during the infancy suggestive of hypotonia. And there is also history of developmental delay. The child could only walk by 1.5 years of age. And initially, there was failure to thrive in the first initial 1 or 2 years. And after that, the child started gaining weight gradually. And with the rapidity of weight gain of 10 to 15 kgs over a period of around 6 months. So the rapidity of weight gain, short stature, developmental delay, history of undergoing right orchidopexy at the age of 1.5 to 2 years, that is suggestive of undescended testis. So all this will suggest it could be a case of syndromic obesity.
Yes, very good. So symptoms depend on the age of presentation, that at what age. So in the initial period, the baby is having fussy eater. So having feeding difficulty and other things due to milestones problems and hypotonia. But again, this child is going to have voracious appetite after some time. So this is really required. And the third, that they are going to have not like nutritional obesity, that they are going to have short stature. So these are the signs of presentation. And can you tell me that about what is the sensitivity of methylation study to rule out the Prader-Willi syndrome? And what is the benefit
DNA
of this MLPA? Probably ma'am is going to discuss later, just for sensitization.
DNA methylation.
Yes.
Go ahead. She'll be discussing and I'll just be joining in, Doctor. So Soumya can go ahead with that.
Yes, ma'am.
We are
Yes.
running short of time anyway.
Yes, ma'am. Definitely. Definitely. Yeah.
So
Question?
DNA
After
methylation.
you. Yeah.
DNA methylation study is mostly confirmatory of Prader-Willi syndrome. It is like it detects deletions in that region of that imprinting, paternal imprinting gene deletions. It can detect well. and but it usually the methylation multiplex PCR will detect all the minor imprinting defects, maternal disomies, and also the translocations along with deletions.
Thank you. So I invite Professor Kavita ma'am for her deliberation, and if she wants to cross-check any question, let me know.
Soumya,
Yes.
I just had a question. I mean, you brought out all the criteria, but suppose we are in a place where we don't have access to genetic test. Is there something, some clinical criteria that can be used in PWS in, major criteria, minor criteria, and in children less than 3 years, 4 years? I mean, do you think it's worthwhile? Whenever we suspect a Prader-Willi syndrome, we can categorize based on the clinical criteria first, after clinical presentation. It's called the Holmes criteria. I don't know if you've heard of it.
Yes, ma'am. There's a clinical criteria also for.
Right. So this child is 7.5 years. Did he meet all the 5 major criteria? He should have had at least. So maybe while presenting, you can first bring out the clinical and then all these other investigations to confirm instead of straight away going to a genetic test for confirming the diagnosis, because that may not be available everywhere, right?
Yes.
So clinically, we need to emphasize on how to diagnose it clinically also. So there is something called the Holmes criteria, major criteria, minor criteria in a child less than 3 years. I think 4 major criteria, and above the age of 3 years, it's 5 major criteria. So some number like that, I'm not remembering offhand. But Holmes criteria is what you need to stress on clinically, because when a case presentation happens for a postgraduate in the exams, they need to be able to diagnose based on clinical criteria, and that is Holmes criteria.
Yes, ma'am.
So that is one thing, and yeah, carry on.
Ma'am, can you proceed sharing the screen, ma'am? I would like to discuss the management as well.
Yeah, sorry. I'll just share.
And also, I'm sorry, and in PWS, in OSA, it's not just the apnea, hypopnea index. Hypoventilation is the major thing. So if we only go with the AHI, we may actually miss out the severity of the sleep disorder, of the respiratory, of the sleep disordered breathing, if we go only with AHI in PWS, because they have central sleep apnea, hypoventilation, and all those things. And that can get missed out if we are only focusing on the AHIs.
Yes, ma'am. So proceeding with the management of this case, I would like to consider the endocrine part of the management first and later on the comprehensive management of the case. Proceed, ma'am. So the role of growth hormone in Prader-Willi syndrome. So benefits being there is decreased hypoglycemic episodes during infancy where there is hypotonia and there is feeding difficulties. So initiating growth hormone within the first year of life will decrease the episodes of hypoglycemia in this infants. There is increased body composition. There is decreased fat mass and increased lean body mass and improved muscle mass. So this will improve the body composition in the infants when started early. There is improved cognitive function and behavior, and also improved respiratory parameters. So initiation of therapy before 1 year of age and continuing it into the adulthood will benefit with all these advantages. And the dose of starting growth hormone therapy is 0.5 to 1 mg per meter square per day. The child has to be monitored with following parameters when the child is on growth hormone therapy. The height, weight, BMI, pubertal status of the child, and any bony deformities, bone age and body composition, there is something called molar insulin-like growth factor 1 by IGF BP3 ratio. Usually when the child is on growth hormone, the IGF-1 levels and insulin-like growth factor binding protein 3 levels are monitored, and they're usually high. So they're an indication of stopping or reducing the growth hormone, titrating the dosage of growth hormone. But this ratio will show us the free insulin-like growth factor 1 levels, which is the actual, which are the actual levels that should be considered for titration of growth hormone levels. So there are normal levels that are to be considered. So this ratio is important rather than considering the individual levels of insulin-like growth factor 1 or insulin-like growth factor 1 binding protein 3 individually. TSH and free T4 levels, HbA1c levels, cholesterol profile, ENT assessment and orthopedic assessment if concerns of sleep disordered breathing or any bony pains present. In case of benign premature adrenarche, like if less than 9 years of age, we have to do hormonal studies like DHEAS, 17 OHP levels, testosterone levels, LH-FSH ratio. All this monitoring should be done frequently at around 3 to 6 months duration when the child is on growth hormone therapy, every 3 to 6 months. So hypogonadism and pubertal hormonal replacement. In these children, there is usually...
Can I just interrupt, Soumya? We don't do
Sure.
the evaluation of the hypothalamo-pituitary gonadal axis before a bone age of around 12. So, because it's going to be low. So, this thing of monitoring the gonadal axis every 3 months may not be valid.
Only
Yeah.
in cases of premature adrenarche, ma'am, if the
No,
child is
and then
present.
what are you going to do? Where is your reference for this? No. Why do we need to monitor premature adrenarche? We don't do that, right?
Okay,
Where is
ma'am.
your reference, Soumya, for this? Okay. Yeah,
Yes,
that's
ma'am.
fine.
Okay. Hypogonadism and pubertal hormone replacement, estrogen and testosterone replacement for induction, promotion, and maintenance of puberty. It improves the bone mineral density and prevents osteoporosis in adulthood when continued. Other endocrine concerns during adulthood, mainly hypothyroidism, type 2 diabetes, hypertension, and hypercholesterolemia. So hyperphagia and Prader-Willi syndrome. This is a cartoon suggesting the pathophysiology behind the
Dr.
hyperphagia that happens in
Soumya, probably ma'am is going to discuss few slides for that. So I think
Okay.
you should stop over.
No, Dr. Jaiswal, let her continue
Okay,
because we are
ma'am.
short
Okay.
of time. We are
Okay,
short of
that's
time.
fine.
So let her
No
continue.
problem.
So hyperphagia and Prader-Willi syndrome is mainly due to dysfunctional hypothalamus that will lead to abnormal central insulin signaling. Which will lead to increased, that will cause fat lipogenesis and fat deposition, and there is decreased leptin sensitivity. So that will result in obesity and excess lack of satiety. So this is US FDA approved drug that was approved in 2025 for the treatment of hyperphagia. This is diazoxide choline, which is a potassium ATP channel activator that will help in decreasing in improving insulin sensitivity and leptin sensitivity. And also it has effects on body composition by improving beta oxidation of fatty acids, and also prevents fatty acid biosynthesis. And also it affects on behavioral, it reduces GABA receptor syndrome. And other clinical trials that could be beneficial in treatment of Prader-Willi syndrome for hyperphagia are Advark. It is a drug of GLP-1 analog, so that is still in trial. And carbetoxin, which is a selective oxytocin receptor modifier, so that is also in trial. And for behavioral concerns, vagal nerve stimulation is under trial. and excessive daytime sleepiness, which is a common complaint in Prader-Willi syndrome. Pitilasant is the drug which is under trial. This could be potential treatment in future for Prader-Willi syndrome. So other aspects that should be considered in Prader-Willi syndrome. So this is a comprehensive treatment plan for this child. So medical and endocrine management, growth hormone therapy should be started in this child. Because the child has severe OSA, start growth hormone of 0.5 mg per meter square per day after 8 weeks of CPAP therapy. Thyroid, the child is currently euthyroid, so we check FT4 and TSH levels every 6 months after initiation of growth hormone therapy. Cortisol levels are normal, so we monitor the levels every 6 months. Metabolic, there is obesity risk. We monitor HbA1c, FBS, and insulin-like growth factor 1 levels every 6 months. And OSA, CPAP hormone. Puberty, pubertal monitoring at 12 to 14 years, and replacement of hormone replacement therapy for initiation of puberty should be considered. Musculoskeletal, dental, and diet and activity. Orthopedic, currently the child has no complaints, orthopedic complaints, so we do yearly review with X-ray pelvis, AP, and standing spinal AP or lateral X-ray. Ophthalmology, currently eyes are normal, pupils are bilateral equal, and fundus are within normal limits. We do yearly review. Dental, finger biting, gingivitis with high sugar intake. So brush after meals, reduce sugary foods, and avoid finger biting. Diet management, prefer complex carbs, fruits, vegetables, good protein, egg, nuts, and sprouts and lentils, and avoid junks. Physiotherapy, structured physical activity program for improving the muscle strength. Exercise, 60 minutes per day, cumulative, start with 20 minutes per day, and fun activities or swimming. Developmental speech and speech education and psychology. So the child will require annual follow-up and assessment. So we should initiate speech therapy in this child. Academics, continued special needs schooling. Language activities, picture talk, conversation skills, and focus on activities of daily living and life skills. Behavioral, psychological counseling, and family therapy should be initiated in this child. Thank you.
Thank you, Dr. Soumya.
Thank you, sir.
I invite ma'am.
Dr. Jaiswal, I think we've had a long evening.
Okay.
Yeah. So it's only 80%, 60 to 80% of the total calorie for the same age children. That is one point I would like to make about food.
Yes.
And then there should be a very structured meal plans implemented with no exposure, the environmental control and all that in PWS. And the amount of protein is a little higher and carbs is a little less in a typical PWS meals. So these are some of the very specific PWS from nutrition perspective. I think with this, maybe we can take questions, Dr. Vijay. I mean, if there are any questions, so that's. Hello.
There are no questions in the chat box, ma'am. So
Okay,
we can continue the next part. If there are any questions, we will let you know.
Yeah.
Oh,
So
thank
that's
you.
it. I think we have exceeded the time also, isn't it?
No, ma'am, we are on time only. Till 8:30 your time was
Oh,
there.
okay. So that is about the diet part of it. And also about things like dislocation of the hip. I would like to make one point clear because they have shallow acetabular. Very often people think that there is a dislocation when they may not be. So even our orthopedic surgeons, we kind of share all the consensus guidelines with them when we refer when we refer them to orthopedics. So the shape of the acetabular gives a wrong sense of subluxation in these children, and we need to be careful about that diagnosis. We need to cross-check, and that's about the food and environmental control should be very strict. Environment in school also should be strict, so we give a handout to the families to hand over to school, because that works better than just us trying to say
Yes.
things.
There is a question regarding the management of severe OSA, and do you start GH simultaneously with the management of OSA, or you wait for some time, you start CPAP and then wait for some 3 to 6 months before starting GH, or you start simultaneously? And
If there is OSA and OSA starts later, not in the first 6 months, when the adenoid starts growing, which is a much later event, so usually that becomes significant later on, and OSA worsens with growth hormone because of the risk of growth of the lymphoid tissue also. So in such cases, yes, CPAP first and then growth hormone. But if we are starting very early, we may want to start, because it's a very dicey situation. The most critical period in PWS is in the first 6 months when they are floppy, they aspirate like crazy, they have micro aspirations, not even the kind of which we may not even recognize clinically, and they keep coming to the hospital with lung infections. So it's like you're caught between a respiratory issue and starting growth hormone, because growth hormone helps that. It improves the muscle tone.
yeah.
So in some such cases, we do start because we know that it's not the age for lymphoid hypertrophy, and so the OSA part may not be a major problem. And another
Mostly
thing, in
patient
less
come
than 6
late.
months, yeah. So in less than 6 months, polysomnography is almost impossible to do. So they say just sleeps, maybe based on the readings in NICU of oxygen saturations, desaturations, we need to have that as a baseline, pulse oximeter readings rather than, or a continuous pulse oximetry rather than a full-blown polysomnography in very small infants. So that is it.
Have you used any surgical management for an OSA apart from adenotonsillectomy? Any other?
Yeah, there is something called, they stabilize the palate. It's called veloplasty or something like that. Yeah. So,
Velopharyngoplasty they do.
right. So again, that has to be a skilled person who is in a high volume center doing these things. Otherwise, it can mess up more. So these are the two surgical procedures. One is adenoidectomy, and the other one is the veloplasty or something like that they call it. Yeah.
Velopharyngoplasty.
Yeah.
Okay.
So these are the two surgical methods.
Thank you.
Thank
Over
you.
to Dr. Vijay Jaiswal for the OSCE session.
Thank you. Thank you, ma'am. And thanks, Dr. Soumya, for your
Thank
nice
you.
presentation.
Thank you, ma'am.
Thank you, ma'am. Thank you so much.
Thank you. Thank you. Thank you for giving us the opportunity.
So the next, that is, we are going to have the OSCE session, because this is the session which is for postgraduate students. So Dr. Anjali is a professor at PGI Rohtak. So I invite Dr. Anjali for her deliberation for OSCE, please.
Thank you, sir. Sir, with this, shall I share my screen for the OSCE?
Yes.
Is my screen visible, sir?
Yes, it is visible. Yes.
So good evening to all the postgraduates. I think few of the postgraduates must have joined by now. So basically, these OSCEs they are covering all those topics which have been discussed, which have been covered in the previous two discussions and all that. So I hope you will be able to answer many of these questions. So shall I start?
Yes, Dr. Anjali, you
Yes,
can
please.
start.
So the first OSCE is a 10-year-old boy presents with excessive weight gain for 3 years. Height velocity is normal. He consumes frequent fast food and has sedentary lifestyle. So as you can see the plot on IAP growth charts. So his weight is above 97th centile and height is somewhat 75th to 90th centile. So what is the most likely diagnosis and what is the cause? And his BMI is much above 27th adult equivalent. Any postgraduate?
So we have few postgraduates. You can ask by.
Priyanka,
So we
Ria, you
have
can unmute yourself. And then the postgraduates who have just.
Soumya have answered exogenous obesity.
Okay,
Dr.
and
Soumya
how?
has answered. Yeah.
Sir, I'm not able to see actually. Should I?
That is in chat box actually. You can see in chat box. Dr. Ria has also replied exogenous obesity from your institute only.
I think it will be better if they can
Yes,
speak so
yes,
that I
yes.
can hear.
So you can come out by your own, not writing. Yeah.
How is
Ma'am, this is a
obesity?
case of exogenous obesity.
Okay, fine. So how is obesity classified in more than 5 years and less than 5 years? Can you be just
More than
quick?
5 years, we use BMI charts, IAP BMI charts to classify obesity. Overweight is when more than 23rd adult equivalent, and obesity is more than 27th adult equivalent. Less than 5 years, we use weight for height charts. So more than 2 standard deviation is overweight, and more than 3 standard deviation is obese.
Can you please tell me why +3 standard deviation weight for height is considered as obesity in less than 5 years, whereas in more than 5 years, it may be around like more than +2 standard deviation or Z score?
In
yes.
WHO charts, it is still more than 95th centile for obesity, ma'am. But here we take 20, that is.
Are you able to understand my question? Like if in less than 5 years, we take obesity as +3 standard deviation, whereas in more than 5 years, it will be near about like +2. So it is because in smaller children, we intend to take chubbier children to be healthy. Because if we'll take +2 Z score in smaller children, then we can diagnose a lot of chubbier children as healthy children, as obese children.
Okay.
So that is the difference between less than 5 years and more than 5 years. So the second question is, 8-year-old girl is brought with progressive weight gain for 1 year. She complains of fatigue and climbing stairs. On examination, of course, BMI came in obese range. Short stature, she was short stature for mid-parental height. She had round plethoric on examination when I examined the patient. It was, she had round plethoric face, oleaceous tri over abdomen, and proximal muscle weakness. And her blood pressure was 138 by 90 millimeter of mercury. That was, of course, in the hypertensive range. What is the most likely diagnosis? Anyone? It's simple.
So in chat box, 2 people have replied Cushing syndrome.
Okay. So which clinical features differentiate this from simple obesity? So of course, these are all the features, which is round plethoric face, striae, proximal muscle weakness, which differentiate this from simple obesity. So what complication should be screened for in this patient?
Good evening, ma'am. Ma'am, we can screen for metabolic complications in this patient like hypertension, dyslipidemia, and ma'am type 2 diabetes mellitus. And ma'am, we can also screen for skeletal complications like growth failure.
Yes, of course. So these are the investigations with which we can evaluate, as this seems to be a case of Cushing syndrome, and we should screen for complications like hypertension, diabetes, bone complications, and psychological disturbances. That is also one of the important manifestation in Cushing syndrome. Now we have a 11-year-old boy who presents with excessive weight gain since early childhood. Parents report that he has difficulty seeing at night for like 1 to 2 years, and he is having poor school performance. On examination, he is obese, he had polydactyly, he had learning difficulties. Of course, IQ was also on the lower side, and he had reduced visual acuity. So what is the most likely diagnosis?
So Priyanka, you can tell.
Ma'am, most likely it is the case of syndromic obesity.
Yes, definitely. At least you are able to tell that this is syndromic. Why syndromic?
Ma'am, because here the classical finding we have is of night blindness. Ma'am, I don't know the name of syndrome, but
And learning difficulties and polydactyly. So the patient is having syndromic features plus learning difficulties and of course visual issues. So this is a case of Bardet-Biedl syndrome. So the three characteristic features of this syndrome are the features which I have told you: polydactyly, learning difficulties, reduced visual acuity, hypogonadism. Which organ system should be carefully evaluated in the long-term follow-up of this patient? So renal system, because there are risk of renal abnormalities and chronic kidney disease in these patients. So another one, a 6-year-old boy is brought with excessive eating and progressive obesity. Parents report poor muscle tone during infancy with feeding difficulty in the neonatal period. He has learning difficulties and short stature. On examination, obese, he had small hands and feet, mild developmental delay, and hypogonadism, although we can't tell at this age. So what is the most likely diagnosis? Anyone? So this was the case which was being presented.
Again, answer is given in chat box only. So they are not coming out directly. Yeah.
You can speak, sir, so that I may be knowing whosoever, because I'm not able to see the chat box.
Definitely, yes.
And which neonatal feature is characteristic of this condition? So neonatal hypotonia with poor feeding. And these are the two endocrine abnormalities which are associated with this syndrome, that is hypogonadism and growth hormone deficiency. I think I should join from my phone also so that I may be able to see who has answered it. So another 2.5-year-old child having severe obesity since infancy, and she had extreme hyperphagia. So this was the patient in our ward. She had that much of hyperphagia that she used to eat biscuits of पास वाले patients. सबके biscuit, सबका खाना रात को खा जाती थी. So she had weight which was more than 99th percentile. Height was between 50th and 75th centile. She had constant food seeking behavior, developmental that was otherwise normal, and family history revealed consanguinity. So what type of obesity is likely?
Ma'am, monogenic obesity, genetic obesity.
Monogenic. So what are the pointers in favor of monogenic?
Ma'am, there is extreme hyperphagia in the child, and the condition started since infancy.
Yes. So the condition started, usually monogenic obesity starts in early infancy to in infancy to late childhood, early childhood. All right.
And ma'am, also family history of consanguinity is also present.
Is also there, and she had extreme hyperphagia, whereas development may be normal in these children. So which genetic pathways are commonly involved?
Ma'am, leptin pathway.
Okay. And mention 2 indications of genetic testing.
Consanguinity and early onset obesity.
Consanguinity and early onset obesity, of course, with history of extreme hyperphagia. That is what it was present in this child. Name one targeted therapy used in selected cases. So this type of obesity is monogenic obesity. The pathways which are involved are leptin melanocortin pathways. And of course, the 2 indications for genetic testing is severe early obesity and hyperphagia. And this is the one targeted therapy which is used in selected cases, setmelanotide. What happens, it bypasses the it is MSH agonist, and what it does that it bypasses the pathway, and it will lead to leptin release and leptin sensitivity, which will lead to satiety in the patient. An 8-year-old girl presents with excessive weight gain and poor height gain for 4 years and abdominal distension for 4 years. On examination, she has coarse facies, dull look, depressed nasal bridge, persistent milk teeth, dry coarse skin, myxedema, and acanthosis. Height was minus 4.37 Z-score. Weight was, of course, on the higher side, and BMI plus 3.24 Z-score. Bone age was less. It was not 7 to 8 years. It was about 3 to 4 years. She has attained menarche, but has only breast stage 2 development with absent axillary hair. So what is the most likely diagnosis?
Hypothyroidism.
Hypothyroidism. So which finding is red flag against exogenous obesity in this patient?
Ma'am, myxedema and coarse faces.
And height?
Yes, ma'am, poor height velocity.
So in simple obesity, exogenous obesity will not have short stature, no?
Yes, ma'am.
So how do you explain attainment of menarche despite delayed bone age and incomplete puberty in this patient? So what do you usually see in hypothyroid?
Ma'am, TSH is in high TSH, which can also stimulate, which can also cause the ovarian stimulation and might cause estrogen production and thus led to early menarche.
What is that called?
Ma'am,
Van Wijk-Drumwatt syndrome. So basically, it is pseudo-precocious puberty due to severe hypothyroidism. The TSH acts like FSH, and then it will stimulate the ovary to produce estrogen, which will lead to pseudo-precocious puberty. So most of the cases of hypothyroidism have delayed puberty, but if there is long-standing hypothyroidism, then it can lead to this entity. So we have a 12-year-old girl with obesity who is evaluated for weight gain. She has no constipation, no neck swelling, no cold intolerance or fatigue. Height velocity is normal. Her TSH is 7.1. and free T4 is normal, and anti-TPO antibodies were negative. And this is a very common scenario which we see routinely in our OPDs, and parents come with this report saying that this thyroid disorder is the cause of the obesity. So what is the most likely diagnosis?
Subclinical hypothyroidism.
And is this cause of obesity in this case?
No, ma'am. Ma'am, because
So what?
height velocity is normal here. And ma'am, that is against the true hypothyroid obesity.
Yes, definitely. So what we should tell the patients and parents, of course, because they are
Ma'am,
very
we have
apprehensive.
to counsel for lifestyle modification and weight reduction, and we can repeat the TSH level after 3 to 6 months.
And when to treat?
Ma'am, if TSH is very high, like more than 10, and anti-TPO antibodies are positive, in those scenarios, we have to treat as early as possible.
So definitely it is obesity associated subclinical hypothyroidism. And this is not the cause of obesity in this case. What happens in obesity? That in obesity, there is increase in leptin, which will lead to increase in deiodinase activity, which can lead alterations in hypothalamic pituitary hypothyroid axis, which will lead to more release of TSH. So that increase in TSH is a result of obesity and is not the cause of obesity. So of course, we have to treat. If we find goiter in the patient, TSH more than 10, positive antibodies, and if there is poor growth velocity. A 9-year-old child underwent surgery for craniopharyngioma 1 year ago. Since then, rapid excessive weight gain has occurred despite dietary restrictions. So BMI was more than 99 centile. The patient had reduced physical activity and of course was short. So what is the mechanism of obesity? Can anyone tell? Actually, I'm not able to see the chat box. Dr. Vijay sir, if anybody replies in chat box, then please let me know.
So hypothalamic.
Ma'am, during the surgery, there might be damage to hypothalamic centers, which might lead in severe weight gain in this child.
Yes, definitely it is. And mention other endocrine deficiencies that should be monitored in this child.
Ma'am, growth hormone, TSH, hypothyroids should be monitored.
So the mechanism of obesity in this patient is hypothalamic damage, which has affected the satiety regulation because those centers are located there. Why is the management difficult? Because the patient had severe hyperphagia and reduced energy expenditure. So of course, the hormones which are being released from pituitary, that is growth hormone deficiency, ACTH, hypothyroidism, that has to be monitored. And this is the multidisciplinary management we have to do in these patients. So a 14-year-old obese boy presents with excessive weight gain and fatigue. He has sedentary lifestyle and frequent intake of junk food and sugary drinks. Family history is positive for obesity and type 2 diabetes. On examination, BMI is more than 97 centile. Blood pressure is also on the higher side. Acanthosis nigricans is present and mild hepatomegaly. Investigation showed fasting glucose of 116 milligram per deciliter, triglycerides 240, HDL lower, 34 milligram per deciliter, ALT raised 102 units per liter, and ultrasound abdomen showed fatty liver changes. What metabolic abnormalities are present in this child?
Obesity.
Ria, I think anyone else? Maybe Priyanka. Priyanka, you are there?
Yes, ma'am.
So can you tell?
Ma'am, in this there BP is more than 130, which is मतलब metabolic syndrome की तरफ जा रहा है मैम. BP more than 130 है. STL भी मैम less than 40 है. और fasting glucose भी more than 100 है मैम. ALT भी raised है.
ALT भी raised है. So liver में what is the most likely liver diagnosis? ALT raised है. So what can we suspect in this child? What the child is having in the
Non-alcoholic fatty liver disease, ma'am.
So why are these children? Why are children with obesity and insulin resistant at increased risk of developing fatty liver disease? Can somebody tell? Because this is somewhat a theory-like question, probably. So this is metabolic syndrome with impaired fasting glucose, dyslipidemia, hypertension, and insulin resistance. And non-alcoholic fatty liver disease, as you have said, and insulin resistance increases fat accumulation in the hepatocytes. It promotes hepatic inflammation, alters lipid metabolism, which will lead to fatty liver disease. So a 12-year-old boy with severe obesity is brought with concerns regarding small genital size and progressive breast enlargement for 1 year. There is no history of galactoria or drug intake. This is also a very common scenario, which we routinely see in our OPDs. So body mass BMI was more than 99 centile, excessive suprapubic fat, which is obscuring the penile shaft, of course. Stretched penile length was normal for the age. Bilateral soft breast enlargement was there. So what are the most likely explanation for the genital and breast findings?
Dr. Ria has answered. Lipomastia and buried penis.
It can be lipomastia. Can it be gynecomastia? Ria?
No, ma'am, because the patient is pubertal. If he would have been pubertal, we can think of pubertal gynecomastia. This can be lipomastia.
So why is gynecomastia common in obese boys?
So, ma'am, because adipose tissues have aromatase activity, so there is more estrogen levels, so it can cause gynecomastia.
It can cause. So basically, there is buried penis due to suprapubic fat, and there can be associated pubertal gynecomastia or lipomastia. And we can differentiate. This has been told already in the first case that stretched penile length is normal in buried penis, but reduced in micropenis. And of course, what you have said is absolutely right. There is increased aromatization of androgens to estrogens in adipose tissue and excess fat deposition in the breast area. So a 6-year-old boy was evaluated for excessive body weight. On examination, he had weight of 35 kg and height of 110 centimeters. He had hyperpigmentation of axilla, groin, and neck regions. So what does this pigmentation denote? So I think you all must be knowing. So someone has typed something in a chat box.
Dr. Naveen, 2 have answered acanthosis nigricans. Yes, 3 have answered.
3 have answered. So
Insulin resistance and acanthosis nigricans.
Insulin resistance. It is a marker of insulin resistance. So investigation क्या करेंगे हम इसके लिए?
HbA1c level.
Riya, हम सबसे पहले HbA1c करेंगे because I think that is
fasting blood glucose, ma'am.
Okay, fasting blood glucose. Anything else apart from fasting blood glucose? Can we go for some other test regarding glucose measurement?
OGTT.
Yes, OGTT we can do. Yes. And anything else? What other investigations we can do? Basically, we have to go for fasting blood glucose and OGTT, and HbA1c is not mandatory in all the patients. The rest we can go for other investigations like lipid profile and LFTs and all that. What musculoskeletal problems can this boy suffer from? Or what are the musculoskeletal issues in obese children? Anyone? Ria, Priyanka? So these are the musculoskeletal issues which these children can have. They may have slipped capital femoral epiphysis. They can have Blount's disease, genu valgum, pes planus. And of course, they can have associated vitamin D deficiency. So an 11-year-old obese child present with loud snoring, poor school performance, and daytime sleepiness. So his BMI was more than 19 centile and large tonsils, and BP was mildly elevated. What complication should be suspected in this patient?
Ma'am, obstructive sleep apnea.
Yes. So what questions should be asked in the sleep history in this patient?
Ma'am, history of mouth breathing and frequent awakenings.
Snoring, poor school
Daytime
performance, sleepiness in the daytime. And which investigation can confirm the diagnosis?
polysomnography.
And what about management?
Ma'am, weight reduction.
Okay, so basically obstructive sleep apnea. And we have to ask about snoring, apnea, if somebody has witnessed that apnea in the night, restless sleep, daytime somnolence, and polysomnography. And of course, we have to go for weight reduction, adenotonsillectomy, and CPAP. So this is the last one, I think. A 2-year-old child presents with severe obesity since infancy and progressive bowing of legs. Parents report difficulty in walking. On examination, the child has marked genu varum with excessive weight for age. What are the two important differential diagnoses for this child? I think the differential diagnosis I have mentioned in the next question itself. Vitamin D deficiency, the child may have associated vitamin D deficiency, or later on he can have Blount's disease. So if there is severe obesity with progressive asymmetrical tibial bowing and normal biochemical parameters, so that favors Blount's disease. And these are the investigations which are helpful in evaluation of these patients. That is, we can go for X-ray, serum calcium, phosphorus, alkaline phosphatase, and vitamin D levels. So I think that's it. Thank you.
So thank you, Dr. Anjali. You have covered all the OSCEs which were related to obesity. Thank you very much. So I will now quickly run through the questions which have been asked in MD-DNB examinations regarding pediatric obesity. So is my slide? Is my screen visible?
Yes, sir. It is visible.
Okay. Okay, so the various aspects of obesity questions have been asked over the years. So questions related to definition of obesity, how we define obesity in children, regarding what is the BMI criteria which are used for diagnosing obesity, diagnostic criteria for metabolic syndrome, WHO, CDC, and IAP criteria for defining obesity in various age groups. Mostly regarding the epidemiology of obesity in India, preventive strategies, and obesity in less than 5 years of age, and the metabolic parameters. Regarding pathophysiology, genetic and environmental factors have been asked. Questions have been asked regarding the insulin resistance in the pediatric obesity and how it leads to diabetes. And some of the questions regarding obstructive sleep apnea and obesity, and genetic syndromes which are associated with obesity and the children. So some recent work, gut microbiome role in the onset of obesity. Questions regarding various molecular markers or adipokines which are related to obesity. And Prader-Willi syndrome, specific questions have been asked regarding Prader-Willi syndrome or case scenarios which have been described, and then asked about the diagnosis and the management part. Then the various clinical assessment questions regarding the causes of secondary obesity or exogenous obesity, defining metabolic syndrome, waist circumference as a measure of central obesity, and the endocrine causes of childhood obesity, and features and investigations which are required to differentiate Cushing syndrome from simple obesity. Question related to polycystic ovarian syndrome, which is associated with obesity, have been asked. Complications related to childhood obesity, and have been asked. Write a short note on the various complications of childhood obesity and how you manage them. Question related to metabolic alcoholic metabolic steatohepatitis, non-alcoholic fatty liver disease have been asked, and cardiovascular management, metabolic syndrome, and various management questions regarding lifestyle modifications and the drugs which have been approved, and the pharmacotherapy and the surgical aspects of the management. So there are multiple aspects which have been asked related to obesity management. So now I will hand over to Dr. Vijay for the final vote of thanks, and Anurag sir for any final comments.
Yeah. So thank you both presenters, Dr. Ria and Dr. Soumya, and thanks to Anurag sir and Dr. Shamkiran for mentoring the thing, and examiner Professor Asma Devas and Dr. Kavita Bhatt ma'am, and excellent OSCE by Dr. Anjali. I am really grateful, and I must appreciate that all the PGs are going to be benefited. And before wrapping up, just a final word from Dr. Anurag Vajpayee sir for the forthcoming. Yes.
Thanks a lot, Dr. Vijay, for this wonderful program. I think this is continuing to go at a very high standard, and we are maintaining and spreading the message of pediatric endocrinology across the country. Special thanks to Dr. Jaivinder for conducting and organizing the event. Along with that, many thanks for the presenters who presented a very wonderful case, Dr. Ashima and Dr. Kavita, who did excellent coordination in terms of assessment and management, Dr. Anjali for the great OSCE that she conducted, and I'm thinking this was overall a very good team effort from everybody, and I'm sure that awareness about pediatric obesity will go a notch with these presentations, and I request all of you to spread these subsequent videos also, which are available on YouTube for all people to access, and we will continue with this aim of improving awareness about pediatric endocrinology amongst postgraduates. Thanks once again, Dr. Vijay and Dr. Jaivinder in particular.
One appeal to all the attendees that 25th is going to be celebrated at World Thyroid Day. So at all your places, please try to keep the awareness or some program regarding thyroid disorder. And particularly, we are more interested in congenital hypothyroid screening, which is a must for all the babies who are going to be delivered in this world. So each and every one are the stakeholder, and please sensitize at your all level. Thank you.
Thank you, sir.
Thank you.
Thank you.
Thank you, everyone. Good night. We can close the session. Jignesh.
Good night. Good night.
Thank you, the tech team.
Okay, sir. I'm ending now.
Yeah. Thank you.